Hey guys, sorry I had to split this up. I'd normally like it all in one video because this is not that long of a lecture, but I had a little snafu, so don't mind me as I split up this blood disorders lecture. So let's talk about aplastic anemia now. So aplastic anemia is a problem where you have low numbers of all of your blood cells. That's low white blood cells, red blood cells, and low platelets. So this leads to a lot of different problems, which we're going to talk about, but it's obviously different than iron deficient, where we had a problem with our supplies in order to make the rest of, to make red blood cells. This is a problem not only with your red blood cells, but also your white blood cells and your platelets. So the causes, it's not well understood. That's what idiopathic means. Like we don't really know. Excuse me. And then we also, there are some, known causes like autoimmune disorders, then some like chemical toxins, drugs, radiation, viruses and bacteria can also lead to this as well. It's more common. You'll see it more common in children than you will in adults, but it can happen in both. So for their diagnostics, everything's going to be low. So this is a little bit easier to remember, is that everything's low. My red blood cells, hemoglobin, low. White blood cells, low. Platelets, low. And then we might do bone marrow testing to see what's going on, because a lot of times they're just not making enough. So if we do some bone marrow testing, we want to kind of see what's going on within the marrow. So these patients are going to have, symptoms of having low of all those blood cells. There's not just one type of blood cell they're low on, it's usually all three. So they're going to have signs of low red blood cells, which we've already gone over. So they're going to have those classic anemia symptoms, the pale, tired, short of breath, weak. But then what's going to be more specific, and anytime you're studying disorders that are similar but a little different, you always want to think about what's different. So what's going to be different about this one is going to be that they have the low white blood cell count and the low platelet count. And so they're going to have signs of what is called neutropenia, which is a low white blood cell count, which at the end of the day, like what my big so what here is that they're going to be at high risk for infection. So the fevers are going to be common. They're going to get types of infections that most other people don't get, or they have to be really like low immune system to get. So we're going to be really doing a lot to protect this patient from getting infection, which I'll talk about on my next slide. They also have low platelets. If you remember what platelets do, platelets help you so that you can clot a lot easier. So if I cut my arm, platelets come to the rescue and help to form this beautiful mesh that helps me so that I stop bleeding. If I'm low in those, then I'm going to have signs of bleeding like petechiae and ecchymosis, which is kind of those bleeding, bruising signs like you can see in these pictures. And then also just be really prone to bleeding. So I have a patient who's pale, weak, tired, fatigued, short of breath, kind of having all these anemia symptoms. And then also they're really high risk for infection and they're really easily bleeding. So you can see where there can be a lot of problems with aplastic anemia. So then, kind of first, we're going to kind of look at each of the blood cells and see how are we going to get to the bottom of helping each of those blood cells. So if there's a known cause, of course, for the aplastic anemia, we have to treat it, because this is one of those things I can, treat the problems or prevent complications. If I'm not getting to the bottom of the problem, which is that I don't have enough blood cells or whatever's causing my blood cells to not be produced or get destructed, et cetera, then, that long-term, that it's just a constant battle in trying to prevent this patient from having like really serious problems. So if there is any known cause, like a bacterial infection, et cetera, like that, I want to treat it. Then in order to kind of manage those low white blood cells, I'm going to do a lot of stuff to prevent infection and to manage this patient from getting really sick. Because like I said, they don't only just get infections, they get infections that are super hard to treat because many people don't get them because they're just so high risk. So we put them in what's called neutropenic precautions. This is also called reverse isolation. And this is where they get no fresh flowers or fruit because there's really high chance of having like, bacteria and other stuff growing on there. And then it's reverse isolation because instead of the trying to protect the, let me say this, instead of me trying to protect me from the patient, whatever the patient has, I'm trying to protect the patient from me. So in other words, I'm going to wear a mask to protect them from getting anything I have. If I'm sick, this is not a patient that I should be taking, even with a mask, because they're just going to be so high risk to getting infection. Now, in today's COVID world, everyone's wearing a mask anyway, so this doesn't matter so much. Everyone's pretty much on neutropenic precautions automatically. But just know in the past, what we used to do is the nurse would be the one wearing the mask going in because I'm trying to protect them from anything I have because their body doesn't have the immune defense to fight it. I'm also going to provide education for how to prevent infection at home. So regular hand washing, staying away from sick people, avoiding those crowds where they'll have a high chance of getting an infection. Doing a bone marrow transplant is sometimes the only thing that can actually help this patient. And it's something when I was in nursing school, I signed up to be a donor. It's super easy. You swab your mouth and send it in. I've been on the list like 11, 12 years now, and I have yet to be called, but I'm hoping one day I'll get to help someone. It's probably the easiest type of transplant to do. They take out some of your marrow from your bone. It is a semi-painful procedure, but they numb you for, but it's easy recovery and stuff like that. So it's a great way to help people. There's a lot of people suffering, not just from aplastic anemia, but people that need bone marrow transplant. So it's a pretty cool thing. So look into it. They don't pay me to say any of this. I'm not advertising for them, but just letting you know that something kind of cool that you can do is sign up to be a bone marrow transplant donor. And so, you know, just know that that is an available thing if you're interested. Another possible treatment might be immunosuppressants. So if it's an autoimmune cause, then I'm going to need to suppress the immune system even more to stop my body from attacking itself, which is causing the problem. But keep in mind, they already have low white blood cells, and I'm going to lower them even more with those immunosuppressants. So I have to watch this patient so closely if they're on those. Then I have to do interventions to help manage their low platelet count. So I'm going to do regular assessments for bleeding. I want to be finding out that they're bleeding as soon as possible, because the sooner I find out, the better, the sooner I can treat it and, you know, help this patient from having serious complications. So of course, you know, I'm going to be looking in all the places. You have to think about your sensitive tissues, my nose, my mouth, my gums and stuff like that, super sensitive. My perianal area, around my urethra, like, so peeing and pooping blood, that's pretty common too. If I have like really moist mucous membranes, this really sensitive tissue. But as the nurse, I also need to know, when is someone bleeding inside? So I'm going to be looking for signs, usually like the early signs of internal bleeding are going to be things like increased heart rate and decreased blood pressure. So really checking those vital signs frequently. If it's in the abdomen, they might have abdominal distension. It just kind of depends. They can also have changes to their level of consciousness, et cetera, if they're really having some bad blood loss. So looking closely for any sign of bleeding, or that they're, you know, kind of managing that bleeding. I'm also going to teach them bleeding precautions. That's using electric razors only. They cut less, so that decreases their risk of bleeding. Because these patients, it's not just that they're bleeding, it's that they can't stop bleeding. So that's the hardest thing. We're putting pressure on them for a long time in order to get them to stop bleeding. We're going to avoid sticks. And when I say sticks, I'm not talking about the kind you find off of a tree. I'm talking about needle sticks. So if I can, like, let's say that the doctor started ordering a bunch of labs. And like it's like 10 o'clock at, like, I work night shifts. So I'm going to do a night shift example. Like the doctor starts ordering some labs at 10 o'clock and says they want them right now. I say, hey, well, I have to poke them again at midnight. Can I do them all at one time? So I want to try to, instead of stick them 5 times in a day, I want to try to stick them just once to try to avoid how many times, or if there's anything I can give in a non-IV form, if I can limit the amount of IVs that they have or how many times I have to stick them, I'm going to preserve my IVs and try to prevent them from needing lots and lots of pokes. No contact sports, avoid trauma. If they're older, we definitely want to do a lot of fall prevention, you know, to help to prevent them from, because like these patients, again, if they fall down, if they like get a bleed in their brain, they may not stop bleeding. And then using a soft bristle toothbrush helps too. And then again, if it's an autoimmune cause, then we'll use the immunosuppressants. So then what do we do for those low red blood cells? We've already talked about this. We do a lot of the same things. We treat the anemia. We do blood transfusion as needed, oxygen therapy, and then those energy conservation techniques help as well. But effectively, think for aplastic anemia, we're going to be treating every problem with each of the low cells. So with the low white blood cells, we're treating their risk for infection. With the low platelets, we're treating their risk for bleeding. And with the anemia, we're treating their risk for poor perfusion. And making sure that they are getting that perfusion they need. And aside from that, all we can really do for these patients is try to get them a bone marrow transplant if that's what they need, or get to the root of the cause of what caused their aplastic anemia. All right, let me take a sip. We'll get started on polycythemia. So polycythemia, are also known as polycythemia vera. This is the opposite of aplastic anemia, where there is too many red blood cells and other cells as well. There's too many red blood cells, there's too many white blood cells, there's too many platelets. But this leads to a very big problem, literally, no pun intended, because there's too many red blood cells, which means I have very thick blood, and there's just this really like high volume of what do you call it, in my bloodstream, which can lead for me to have a high risk of clotting. So when you think polycythemia, really think about the big issue here is that they're super high risk for clotting when they're having issues. So there's a couple types of there's secondary polycythemia. We really focus on primary in this class. So primary polycythemia, it may have a genetic component where, what do you call them? Like people that it's in your family history that you're at higher risk for getting it. But it also, what do you call it? It's something to kind of keep in mind is that the problem is not just that you have too many cells in your bloodstream. The problem is also that then you also get like, there's this, like your body is trying to get rid of all these excess blood cells, and then it can lead to other problems like your spleen getting really big or your liver getting big. That leads to other problems because there's all the waste products of you breaking down your cells. But overall, the big picture here is I have this really thick blood because I have too many cells. It leads me to high risk of clotting. And just because I have a lot of cells doesn't mean things are going well. So let's get a little bit more into this. So just like with aplastic, everything was low. For polycythemia, everything is high. My red blood cells, my hemoglobin is up. White blood cell count, up. Platelets are elevated. And like I just mentioned, there's too many blood cells. That means my body works on a feedback loop. And so if it senses I have too much of something, it's going to try to get rid of it. So if I have too many blood cells, it's going to start breaking down or destructing these blood cells, which means I have more blood cell waste products. And one of the waste products of having, of breaking down blood cells is what's called uric acid. And this leads to symptoms of like gout that are super uncomfortable and a lot of joint pain and stuff like that. So what does this patient look like? So this patient is going to look different than those other anemia patients we talked about. It's almost the opposite. I have too many blood cells. They're going to have generalized itchy skin or pruritus. And this is a result of like, when your body has too much of something, it tries to get rid of it wherever it can. That includes getting it out through your skin. And so sometimes these waste products and everything are trying to come through your skin, which can lead to really, really itchy skin. They can also have paresthesias or numbness and tingling. You have to think all these cells in the blood, when they get in those tiny little capillaries, they're decreasing blood flow. So they can actually lead to some paresthesias, that numbness and tingling in their extremities. There's erythromegalia, and that's like a painful burning and redness of the hands and feet. I talked about the enlarged organs already from all the like the waste of the extra blood cells that the body's trying to get rid of. And they can have a general, like really red or ruddy complexion known as plethora. And so again, like, thinking anemia, there's not enough red blood cells and I'm pale. So and polycythemia, I have too many blood cells. Think that poly, too many. And I'm going to have that kind of like that red tint to me. Hold on a sec. I swear one day I'm going to die from talking so much. Excuse me. All right. So how do we treat this? So we want to decrease their risk for clotting. And so you may think, oh, we're going to use anticoagulation, but we're actually going to use antiplatelets. So I've done like some research and stuff in this, and there are some times that they do use anticoagulation, but usually what they do is just use antiplatelets. So decrease your risk of clogging. So remember, antiplatelets help you to stop clogging so much. Anticoagulants help you to actually prevent blood clots. So even though they're at risk for clotting, we're going to decrease their clogging with things like aspirin or clopidogrel. The biggest thing we need to do is stop the process because we have too many cells. Because remember, I have too many red blood cells, white blood cells, and platelets. So we need to stop making so many. So what we can do is use bone marrow suppressants. If I'm making too many, I'm going to suppress the bone marrow from making so many cells. I also want to make the blood less thick. Excuse me. And I'm going to do that by doing what's called phlebotomy, which you've probably heard of, is where they go in, the phlebotomist goes in and draws your patient's blood. But this is actually like a chosen phlebotomy. Like we go in and we take their blood like to remove some of it because they have too much of it. So effectively, I'm trying to lessen their supply by literally just removing, and they'll go in like once a month or a couple times a month and have their blood removed. Additionally, I'm doing every like 5 seconds here. Don't worry, eventually I'll get to the end of this PowerPoint and stop coughing. And I promise I won't do any more tonight because obviously my body's telling me I've talked too much today. We want to hydrate them and make sure that they, we can kind of like not thin out their blood, but dilute their blood by giving them the hydration and things that they need. So in other words, we give them more fluids to help to thin out a little bit of that, the thickness in their blood. So also because of the symptoms they had, we talked about the itching and we talked about too much uric acid, they may need some medications to help with that. So we might get them medications to decrease their uric acid, like anti-gout medications like colchicine or allopurinol. And then we're also going to give medications to decrease itching, like antihistamines that might help with some of those uncomfortable symptoms. But overall, what we're trying to do is we're trying to prevent their risk for clotting by giving them antiplatelets. We're going to try to thin out their blood through more hydration, getting rid of more of their blood, like draining them of some of their blood, and then suppressing their bone marrow so they're not making so many cells. And then in treating their symptoms and trying to make them more comfortable so that they can go throughout life. And hopefully, like if it's primary, which might have been like a genetic or other cause, you know, and they might always have it and need these treatments for the rest of their life. But if there's a secondary cause, because there are secondary causes of polycythemia, then hopefully it's something that can pass. But anyway, those are your blood disorders. So now let's talk about blood transfusion. So we used to give whole blood, like literally just gave every part of the blood, like people would donate their blood and we give the whole thing. But now we really focus on giving components, just giving them whatever they're missing. So we give red blood cells or we give platelets, FFP or fresh frozen plasma in cryoprecipitate or cryo. Those are like clotting factors. So, but what like pretty much what someone does now is they separate all these things. So we pretty much just want to give back whatever people are missing. So I'm going to talk through the different components, but just know you don't have to know these crazy in depth. We just want you to understand at a basic level what some of these are, because you may find yourself in these. Don't get too caught up in the numbers. We're not going to test you on this. I'm talking for my class. I don't know what your professors, if you don't go to my school, what they're going to test you on, but I can just speak for, we're not going to test you on like how many points it's supposed to go up because it just varies, or how many mils it's going to replace. We more just want you to know, why are we giving this? So PRBCs or packed red blood cells, those are given for blood loss. And like I said earlier in my other video, we usually don't give them unless the hemoglobin is less than 7. 1 unit can increase your hemoglobin by about 1 point or your hematocrit by 3%. And it's about 500 mils in each of those bags. So this is all about blood loss. So we usually, if I'm missing blood, I'm going to replace it with blood. Then there's platelets. And just kind of like keeping with the theme, it's when someone has low platelets. It also can be given to patients that have bleeding that's caused because they have low platelets. So effectively, I'm giving it to people that have low platelets. Sense the theme? I know I'm kind of annoying. So it can increase their platelet count by up to 5,000. And effectively, I'm giving this because I want to increase the patient's ability to clot. Remember, we talked about having low platelets puts you at risk for bleeding. So we definitely want to replace this to increase the ability of increase the ability for people to be able to clot so they don't bleed to death. There's also what's known as FFP or fresh frozen plasma. This is used to treat bleeding that's caused by a clotting problem. And most often when we give it, we're giving it to patients that have too much Coumadin or warfarin in their system. So it's actually a reversal agent. When your INR is super high, we can give it to help to bring that INR down. So once again, this increases your ability to clot. But, you know, you're going to see for the last one, the next one, those are all increase the ability to clot, but we always want to replace what's missing. So we do other tests to see what the problem is. Like if someone just has low platelets, giving them FFP is not going to help. But if someone has a high INR, this is the product for them. Then there's cryo or cryoprecipitate. This has a bunch of different clotting factors. So this is great for people that have had, you know, mass transfusions. It's a part of the MTP or mass transfusion protocol, bleeding after surgery. We use it for a lot of traumas. And it increases your ability to clot. So especially if you're having a problem, like a lot of times traumas are really, they're using up all their clotting factors and stuff from all of the injuries and stuff they have. This helps to replace some of them. So let's talk basic principles. So what are the things that I need to consider as the nurse before administering blood? Well, first I need consent. So this is something, everyone has to give consent. It's a big thing. You cannot give those blood products without consent. And part of when I'm signing off with another nurse saying that this blood is safe to give is that I'm verifying that the consent has been obtained. And so you always want to check that first, and that's something you want to have before you even go and grab that blood, because if it's going to take a minute, if you need a translator, if the patient can't speak for themselves, if you have to get in touch with family, you don't want to have that. We'll talk about this, but you can't, you can't keep that blood up there just waiting forever for consent to be signed. So always have consent before you go and get that blood. You're going to need IV access. And, generally we like to give it in an 18 or a 20 gauge, but just know that we can give, blood products in any size catheter. It's not like if someone comes in and all we can get in them is a 22 gauge, we're not going to be like, sorry, we can't give you blood. Now, the only exception there is I can't use like a rapid transfuser in a 22 gauge. Like, so if I'm going to rapidly transfuse, blood, I'm going to need a bigger IV, but just for a basic transfusion, any IV access will do. Of course, the bigger the gauge, the more it's preferred. So it's less chance of clogging or clotting off that IV. And we also use what's called Y-type tubing. And that's this tubing that's here. This is, it's called Y because it looks like a Y, and the one half is like the normal saline and the other half is going to be your blood product. And this allows you to, when the blood is done, then to get that fluid going. And also if you have a reaction, you have the fluid already hanging and you can just flush in and flush right through in that IV. It also, like I'm saying, like I was just talking about, this is a blood kit, just like there's certain medications that can only be given in certain fluids. When it comes to, blood, you can only hang it with normal saline. It's not compatible with any other fluids. So you always want to make sure that you're only hanging it with those fluids that are safe, which is NS. So the general procedure is we're going to do safety and identification check with 2 nurses, and 2 nurses have to sign off on blood. We need to get a baseline set of vital signs, and that's usually going to be like before we even go and get the blood, we want to see where the patient's at, because we're going to look for subtle changes, because usually transfusion reactions are going to show up in your vital signs. Once the blood is released, like the person goes down, if there's you or the tech or whoever's going, goes down and gets it and picks it up, you have 30 minutes from the time it's picked up to actually is where it's starting to drip into the patient. So you definitely if you're not going to go get the blood, then you need to get all your supplies ready, have everything hanging. I usually have my NS hanging. All I have to do is spike that blood, scan it, and get it started. And you always want to remain with the patient for the first 15 minutes. And you want to be looking for any sort of acute reaction, like what changes and things are they having. And because usually the most serious or deadly reactions are going to happen in that first 15 minutes. It's not that afterward we're like, we're good. They can still have a reaction, but the most dangerous ones are in that first 15 minutes. The blood is cooled in a refrigerator, so we may need to use a blood warmer for administration, especially if they're receiving multiple of those transfusions. And it should be completed within 4 hours, and that reduces the risk of them getting a bacterial infection or having a problem. So overall, it needs to start going into the patient within 30 minutes, but it shouldn't take more than 4 hours for the whole bag to go into the patient, if that makes sense. So those are just some basic principles. So why do people have blood transfusion reactions? Well, because their body says, hey, this is not me, or it starts to react, and it overreacts sometimes. It can overreact in an allergic, sense. It can overreact in that it starts to destroy it. It can put too much fluid in the body. There can be bacteria in the blood. They can have too many transfusion. There's a lot of different things that can happen. The only way to truly prevent like a really serious transfusion reaction is to make sure you do a good type and cross match. In other words, make sure that you've sitting down and that you have the right patient, right blood. So doing that 2-nurse sign-off is key to make sure to prevent transfusion reactions. Now, it can't prevent every transfusion reaction because some of them are not related to the type of blood it is. However, this is going to help prevent some really serious ones. We're going to start talking about the really serious ones. The first one, probably one of the most serious ones that you can have, is what's called an acute hemolytic transfusion reaction. This is where there is breakdown or hemolysis of the red blood cells. And usually it's going to happen in the first 15 minutes, which is, again, why we want to be there in that first 15 minutes. So I always like to think of this, if you're a Star Wars fan, as like the blood enters the body and then your body's like, no, this does not belong. It's like the dark versus the light. And then what do you call it? Your body gets out the lightsabers and starts literally slashing up these red blood cells that are coming into your body. Well, this leads to a lot of problems because you have all these slashed red blood cells that start clogging up the place. You're also not getting what you need through the blood cells, which leads to a whole other problem. But here's some symptoms that you have. You can have a fever. Your heart rate jumps up, your body's reacting, your blood pressure drops because there's this intensive, anytime your body senses something that's not you, there's this great vasodilation, but there's this slashing of all these blood cells. So a lot of times these patients, if they're receiving a transfusion, their blood pressure probably isn't already amazing. And so it leads to even more problems. But then also they can have those split up blood cells can start clogging places. They can lead to shortness of breath, back pain, and chest pain as well. You want to stop, and you're going to find this as a general pattern. We generally always stop the transfusion. So that's kind of the general pattern. I'm going to stop the transfusion as my first action. What we're going to do then is we're going to keep the IV line open with IV fluids. What I mean by that is we're not taking the IV out. We are going to flush it and make sure there's fluids going through it to help dilute the I just hit myself in the face, yes. We're trying to dilute the hemolysis that's happening in the body and get that blood pressure up. And then we're going to draw blood samples, and we want to actually identify that hemolysis is what's happening. And I'll talk more about what we do when we suspect a blood transfusion reaction. I have a different slide for that. So there's a lot of different types of blood transfusion reactions. So start trying to figure out what's different about these, or how you're going to see that this is what your patient is experiencing. So a febrile reaction is the most common. So what happens with this type of reaction is there's sudden chills, fever, and the temperature rises greater than 1 degree Celsius. They may have a headache. And for these patients, we want to stop it and then give an antipyretic like acetaminophen for these patients. Then there is allergic. So this might remind you, and I'm going backwards making these videos, but you should have already learned about, hypersensitivity reactions if you're watching this. And so with hypersensitivity reactions, remember kind of what those looked like. It could be mild, where they're just having I'm giving the blood and they're just starting to kind of have itching, or they can have like a skin reaction like rashes or hives. Of course, for that, we're going to stop it, give antihistamines and steroids. Now, if we know kind of like we talked about when we talked about hypersensitivity reactions, if I know a patient is going to react this way, sometimes we can pre-medicate them and then they won't have a reaction, for the future if they need blood transfusions in the future. There are more severe, and hold on one second. Sorry about that. We can, prevent them from having that reaction with mild. There's also a severe allergic transfusion reaction. Think like anaphylaxis. So they're going to have all those signs like dyspnea, shortness of breath, wheezing, shock. They can go into complete cardiac arrest pretty quickly too. Obviously, we want to stop the transfusion and treat it like anaphylaxis. Give the epinephrine, steroids, albuterol, IV fluids, antihistamines, all the whole gamut. Now with this one, we're not going to just be like, hey, they had an anaphylactic reaction to blood before, so we can give it again. We'll just prophylactically use epinephrine. It's a little bit different with this one, but obviously if they're having a very, very severe reaction, we're going to want to prevent them from having that severe reaction again. Anyway, on to the next one. So then there is Circulatory overload. So this is where a patient has, especially if like people will be at risk, is those that have heart problems and kidney problems, especially like think like heart failure, is that they can't, it's not the, they need the blood, but the fluid in the blood is too much for them. It's 500 mils, which for a patient, some patients with heart failure, they're only allowed to have like a liter and a half a day. So that's like a good chunk of the amount of fluid they're allowed to have. And we're giving this over a few hours. So it can just be too much for their heart or kidneys to handle. So they're going to have signs of like overload, like shortness of breath, wet lung sounds like those coarse crackles. Their heart rate can get fast. They can have distended neck veins or JVD. They also can have high blood pressure as well, all these signs of too much fluid. So for this patient, I want to place them upright so that they can breathe better. We're usually going to get a stat chest x-ray. Of course, they have to get ordered. We're not going to just do one. We're going to take a look and see what's going on in their lungs. And a lot of times they're going to need diuretics. And just know for patients, like a lot of patients we know are not going to handle fluid well. Like I will give them, like let's say they need 2 units of blood. I might give them a unit of blood, give a diuretic, and then give the second unit. You may be thinking, well, don't they need the fluid? They don't need the fluid. They need the blood cells. So for some patients, it's not about the fluid that they really need. They really just need those blood cells. Then there's sepsis, which is, and this doesn't happen often because this is what a lot of people are worried about. A lot of people will be like, oh, I don't want to have any blood products because I'm worried it's dirty blood. We test the blood extensively and stuff like that, but it is possible that people can have bacteria infected blood, or sometimes, like I said, people don't follow those precautions and take care of the blood the way they're supposed to. So then it ends up getting bacteria in the process of giving it, not that it had it in the first place. So for them, they're also going to have like a rapid onset of chills. And now when it says rapid onset, it's usually going to be, it's not going to be as rapid as that febrile reaction, but it's going to be shortly thereafter, like we've given the blood, they're having a high fever, and then they're going to show signs of shock, like a low blood pressure. They can also have gastrointestinal symptoms as well. We're going to treat it like we treat sepsis. So blood cultures to see what the bacteria is, give antibiotics to treat that infection, then give IV fluids and vasopressors as needed. Last but not least, there's what's called a massive transfusion reaction. This is from having too many blood products like at one time. So this is patients that are maybe traumas and received a whole lot of blood products or had a lot of blood loss, et cetera. And so they're going to have all the signs of receiving too many blood products. So they can have electrolyte imbalances and then temperature imbalances. Like I said, it's refrigerated. So if you have too much of it, your body temperature can go down, so you can get hypothermic. Abnormal heart rhythms as a result of them having low calcium and high potassium. And that's just because of what is in those blood products. So what are we going to do? We're going to warm the patient. We're going to treat those electrolyte imbalances, replace the calcium and decrease the potassium, and then monitor their electrolytes closely. So I was talking about, like, overall, I was going to talk about how to respond in general. So if you have a blood transfusion reaction, stop the transfusion. That's usually always going to be the first thing you want to do, because like, even if you're like, oh, it's just a mild allergic one, I'll give them something, they'll be okay. I'm not going to sit here and say like, oh, they're just mildly reacting. I don't know what it's going to become. Stop that transfusion. Keep that IV line open, that saline. That's why we have that saline hanging. And so we're going to flush out whatever's going on. And so, what do you call it? The only time we might not do that is in the like circulatory overload one, but I promise we won't have any tricky questions where it's like, oh, well, in this one, you're not going to want the fluids. And generally we want to keep the fluids flowing open for a majority of them. We're going to notify the blood bank and the doctor, recheck, make sure that we didn't miss anything when we're going to look at those tags, identification numbers. We're going to watch their vital signs for changes in their urine output, because especially with that hemolytic reaction, they can go into rhabdo or rhabdomyolysis and end up with kidney failure, et cetera. So I want to watch their urine output closely, treat whatever symptoms they're having per what the doctor orders. I'm going to save the blood bags in the tubing and send it back to the blood bank. They're going to do their own testing. If there's any required blood or urine samples, like looking for that hemolysis, et cetera, I'm going to send those. And then I'm going to document my butt off and make sure that I'm documenting, hey, there was a reaction that happened here and here's what I did about it. But that's the overall, response that I want to do there. One other thing to consider is that there are some people that do not accept blood transfusions. And so just know that there is some religions that don't believe in receiving blood transfusion. So it's a sensitive topic. So just have an open mind. I always, when people say that they don't want a blood transfusion or they don't want that, I always like to ask them like, oh, okay, you know, can I ask about, you know, the reason behind it? And it's not because I'm getting in their business, but sometimes people just aren't educated or they don't really know what that means. So you always want to make sure that you, and it's really the doctor that should be having this conversation. But what I mean is that sometimes when people are just asking me, like generally, or I'm doing like the admission questionnaire, it comes up. And it's okay to talk to people about it if they did, like, you know, sometimes I'll just be like, oh, is it a religious reason? Or do you have any questions, or can I answer anything about any concerns you might have about having a blood transfusion? We're not here to push it on them, but it's just good to know because some people just don't know what it entails. And so it is our job as the nurse to be an educator. Know that parents or guardian can refuse care for a child if they're competent, or like, you know, people can refuse for themselves. These can get into ethical debates and problems. So just know that that's possible. It's not always just that just because they say no, because sometimes I've taken care of a patient with a hemoglobin of 3 that did not want any blood products. So we did everything we could because they were legally able to make their own decisions. But, you know, other people, and like sometimes you can work with the people in their community in order, because like they have liaisons and stuff sometimes that can help to say, hey, here's all the things you can do so that this person does not we can respect their religious wishes, but also make sure that we can treat them too. Because sometimes, you know, anemia is no joke if your blood volume gets low enough. So anyway, that is the basics. I know there was a lot there, and there's a lot of different types of blood transfusion reactions. Just focus on what's different, and overall, you know, the whole process of how we're going to stop the transfusion, and then what's next, how we can best help that patient. And hopefully this got you started getting excited about learning about anemias and other blood disorders. So there's other shorter, simpler videos if you want them. Remember, this is the long lecture. So hope it helped. See you for the next one.